My name is Josh Rescherkoff. I'm a resident at Cedars-Sinai, and this is my poster on a case of pseudohypoglycemia. Before jumping into the case, I wanted to review a few definitions. First, hypoglycemia is defined by the Whipple triad, involves three things: symptoms of hypoglycemia, low blood glucose levels, and then resolution of those symptoms with a normalization of glucose levels. On the other hand, pseudohypoglycemia describes a phenomenon where there's discordance between the point-of-care glucose measurements and the plasma glucose values. And now on to the case. A middle-aged woman with a history of hypothyroidism and lupus presented to the ED after a fall. The events around the fall were fairly unremarkable. She felt a little lightheaded after standing up, tripped, and then fell. She denied any previous history of falls, denied any loss of consciousness, palpitations, clamminess associated with this episode. She had no personal history of diabetes, no family history of diabetes, lived with no family members with diabetes, and nobody in her immediate circle worked in healthcare or otherwise had access to diabetes medications or insulin. Family and social history were unremarkable, and only medications at the time of admission were hydroxychloroquine and levothyroxine. On arrival to the ED, she was afebrile, blood pressure was in the 140s over 70s, heart rate in the 60s, and she was sitting well on room air. Her exam, she was alert and oriented, pleasant, very conversant, had a really unremarkable exam aside from a little bit of tenderness from where she fell. Her initial labs were notable for a point-of-care glucose of 34. After this value, she received multiple ampules of dextrose in the ED, and a repeat point-of-care revealed less than 10. Given these point-of-care results in the emergency department, she was started on a D10 drip and admitted to the ICU for refractory hypoglycemia. When she arrived in the ICU, the BMP that had been sent when she first arrived in the ED resulted with a plasma glucose of 80. That was at the same time when her point of cares were 34 and then less than 10. Her hypoglycemia lab panel was unremarkable. Sulfonylurea screen was negative. Her D10 drip was continued because her point of care test continued to show hypoglycemia with values in the 40s and 50s as seen in figure 1, but her BMP had normal glucose values in the 70s, 80s, and 100s. Similarly, nurses were reporting difficulty obtaining a reliable waveform on her O2 stat based on the fingertip monitors. She was eventually transferred to the ward, and on more detailed history taking and physical exam, it was revealed that she had distal narrowing of her fingers, and she endorsed pain and discoloration when she would experience cold temperatures in her fingertips. She was asymptomatic throughout her entire hospital course, despite these low values in the 30s and 40s on her point of care tests. Eventually, her D10 drip was discontinued, and given her clinical stability and that she was asymptomatic, diagnosed with pseudohypoglycemia and discharged home. This case underscores the importance of interpreting point-of-care glucose measurements in the setting of physical exam and clinical context. Pseudohypoglycemia is thought to be related to poor capillary flow and peripheral vasoconstriction, and cases have been described in patients with Raynaud's syndrome, likely what this patient had undiagnosed, Eisenmenger and acrocyanosis, as well as in patients who are critically ill in the ICU. This is an important reminder that in order to diagnose hypoglycemia, both laboratory and clinical data need to be interpreted and incorporated into the diagnosis.